Thanks for coming to my talk, Buprenorphine for Chronic Pain, Transforming Our Most Challenging Patients into Our Greatest Success Stories. I really don't have anything to disclose. I can forewarn you that this talk is going to sound like a commercial for buprenorphine, but I can promise you I don't have any relationships with any of the companies that produce buprenorphine. We all know what chronic pain is. This is a 30-minute slide deck condensed into 15 minutes, so I'm going to blow through a lot of these slides. But there's been a lot of talk about the pain management best practices interagency task force, and we know that pain is prevalent and expensive. Non-opioid medications have their own issues. They are not risk-free. Conventional opioids, there's really zero evidence for long-term efficacy. They're great for short-term, acute pain, not so much for long-term. And the reason is because of their mechanism of action, and that is full activation of mu receptors in the central nervous system. That produces opioid-induced hyperalgesia, that produces the side effects, and that also activates the reward pathways. And this is what leads to opioid use disorder and overdose deaths. But there's a lot of talk about overdose deaths, opioid use disorder, and my argument is that that's really just the tip of the unwanted iceberg. There are tons of people out there who are suffering from chronic pain, who are taking their medications as prescribed by their physician. They are not addicts, and yet I think they're suffering needlessly from loss of efficacy, opioid-induced hyperalgesia, side effects, and hopefully by the end of this talk, you'll share that opinion as well. Buprenorphine is a different drug. It's an atypical opioid. It's underutilized. It does come from the poppy. It has this mixed action agonist-antagonist effect at 4 different receptors. This talk really segues well on all the talks earlier today in that this is a medication that works on mood as much as it works on pain, and maybe that's really the point. It's a Schedule III medication, so there's less misuse potential. You can phone it in. You can put refills on this medication. It has unique pharmacodynamics. And if you don't take anything else home from this talk, there's a few slides that I'm really going to point out to you. And one is this ceiling effect for respiratory depression, but not for analgesia. And that's a big misconception about buprenorphine. Because it has this ceiling effect for respiratory depression, many of us assume that it has a ceiling effect for pain relief. And I hope by the end of this talk you'll see that that's not the case. So this orange line here is a conventional opioid. And as you go up on the dose, you rapidly go from analgesia to respiratory depression. So that therapeutic window is really pretty small. With buprenorphine, the blue line, after achieving analgesia, it kind of flattens out. And so you have a much bigger therapeutic window here where you can use this medication. It's a safer option. Here's the 4 different receptors: mu, delta, kappa, and ORL1 type receptor. And let's talk about each one individually. So the partial mu agonism. This is a partial mu agonist. And what do we mean by that? That it doesn't fully activate the mu receptor? I think we have to clarify that when you activate a mu receptor, there are 2 intracellular downstream signaling pathways. And one is the G protein pathway, which we like. That produces the analgesia, the good stuff. The beta-arrestin pathway is also activated, and that's where you get the side effects and the opioid-induced hyperalgesia. Buprenorphine preferentially activates the G protein pathway. So it's a little bit like a COX-1 and a COX-2 inhibitor in the sense that we're trying to activate more of the good stuff and less of the bad stuff. Buprenorphine also facilitates migrate of mu receptors to the cell membranes, which increases efficacy. It dissociates more slowly from the mu receptors, so you get this prolonged analgesia and less end-of-dose withdrawal pain. And that's important. I want to talk to you about that more in a future slide. But this high affinity and tight binding and long duration is why we use it in opioid use disorder, right? It reduces cravings and withdrawals, and you get this competitive inhibition. If someone tries to use their drug of choice, they really don't experience euphoria. But this talk isn't about that. Today, I'm talking about buprenorphine for chronic pain. But it's kind of similar in that it's fast onset and long duration, blocks cravings and withdrawals. It also blocks pain. You don't get as much end-of-dose pain. Buprenorphine has this preference for the spinal cord. It preferentially activates mu receptors in the spinal cord. So it's a little bit like I guess, an intrathecal pump, right? You're getting the drug acting more where you really need it and less where you don't. So delta and kappa receptors, buprenorphine is an antagonist. And this confers, benefits as well, especially in regards to mood. It has this antidepressant, anti-anxiolytic, anti-hostility effect with reduced suicidal tendencies. There's less side effects due to the activation of these two receptors. So you see that this multiple mechanism of action that buprenorphine has versus a conventional pure mu agonist has advantages. This ORL1 receptor agonist blocks the reward system, so it's better long-term efficacy, lower potential for misuse, and it also contributes to its analgesic properties. When you take this drug sublingually, the onset is 5 to 15 minutes. It's a very rapid onset. If you watch somebody who's withdrawing take this, it's pretty amazing to see how they go from kind of a wreck to a really calm, happy person pretty quickly. There's less immunosuppression with this drug. There's less constipation. Let's talk about misconceptions. This is another one of those take-home slides, right? Partial agonism has been misconstrued as partial analgesic efficacy, and I'm going to hopefully prove that that's not true. There have been clinical studies for various conditions, including acute surgical pain, acute renal colic, cancer pain, showing that buprenorphine has efficacy equal or superior to conventional opioids like morphine, oxycodone, fentanyl, sufentanil. These are the strongest opioids that we know of, and buprenorphine works better. This might be a surprise to you. Some argue that buprenorphine is 25 to 100 times more potent than morphine. That might be from an intravenous study. I don't really experience that in my practice, but I tell people it's 20 times as potent for sure. Other misconceptions. In the United States, buprenorphine is considered an addiction drug. We have two medications that are FDA indicated, buprenorphine FDA indicated for chronic pain, but it's most well known as Suboxone, as the drug that we use sublingually for opioid use disorder. Buprenorphine was developed in the 1960s in Europe for pain, and it was used over 30 years before it got FDA approval in the United States for opioid use disorder. That was in 2002. Another misconception is that we think buprenorphine is an end-of-the-line kind of drug for people who failed other opioids. But that interagency task force that Vanilla and Peter have been so instrumental on recommended buprenorphine as a primary therapy. And because it's got better efficacy, better tolerability, lower risk for misuse, and respiratory depression. So we should start thinking of buprenorphine sooner in the treatment algorithm. In my practice, I'm using it a lot really for patients who are chronic opioid users and who are not doing well. And sometimes even if they are doing well, we talk to them about this drug. It doesn't get absorbed well through the GI tract, only about 15% bioavailability if you swallow it. Fortunately, it is very well absorbed transmucosally and transdermally. And so that's what the formulations are. We have this transdermal formulation, the buprenorphine patch. The brand name is Butrans. It's now available generically. This is okay for people who take less than 80 milliequivalents of morphine a day. And remember, this is FDA indicated for chronic severe pain. It's not for addiction. I think 80 is a little high. I don't know if I can get someone on 80 to take the Butrans patch. We also have a buccal formulation. It goes in the cheek. This is known as Belbuca, and it's good for up to 160 morphine equivalents. I think that's pushing it. And it's FDA indicated for severe chronic pain. And then, of course, we have the sublingual formulation everybody's familiar with. Most famous one is Suboxone. It's suitable for any morphine milliequivalent, off-label for pain. This is the one that's indicated by the FDA for opioid use disorder. This is the one that you need a special license to prescribe for opioid use disorder. I use Suboxone probably more than any of the other formulations in my practice just because it gives me more flexibility, especially when I'm starting out. So I'm going to kind of recap. We have these multiple mechanisms of action, less respiratory depression, less OD risk, better efficacy, rapid onset taken sublingually. It's got this long half-life, so less end-of-dose withdrawal. And man, I'll tell you something. The main thing I hear from people is they're sleeping better, and we all know how important that is. Less tolerance and hyperalgesia, greater long-term efficacy. I think that if you talk to anybody who uses opioids daily, they'll tell you that sleep is a big issue. And I think that it's probably due to nighttime withdrawal. They all wake up with that horrible pain and they can't wait to take their meds. You switch them to buprenorphine, that goes away. People wake up and they're like, oh, maybe I should take my morning dose. So greater long-term efficacy, less euphoria and abuse potential. It's great for coexisting opioid use disorder. And if you look at what an opioid use disorder is, there's 11 criteria in the DSM-5, and one of them is tolerance and the other one is dependence. So 2 to 3 out of 10 equals mild opioid use disorder. So I would argue that anybody who's taking a daily opioid has at least a very mild opioid use disorder. We have less side effects. It's a Schedule III. It's generic. These different formulations avoid the GI tract, which is important. We'll talk a little bit more about that. It has this tissue specificity, so it's like a sublingual pump. I mean, go with me on that one. It's got this antidepressant, anxiolytic effect, so better mood, better sleep. But there's more. We're going to talk about some specific populations, and we know that cancer is painful, and RCTs have demonstrated efficacy. They've shown that they're as effective as the other pure mu opioid agonists. Systematic reviews show it's as effective, but lower risk for tolerance and better tolerability. These formulations avoid the GI tract also, which is important for people who can't swallow or for people who have nausea and vomiting related to their cancer or chemotherapy. Neuropathic pain, traditional opioids don't work. We do it anyway. Buprenorphine actually dampens central sensitization, and a consensus panel on pain and opioids recommended buprenorphine as it shows a distinct benefit for neuropathic pain. No other conventional opioid can claim that. In older adults, pain is more common and treatment options narrow. And so we're looking for something for these patients. They have polypharmacy, comorbidities, PK, and pharmacodynamic changes. But buprenorphine is highly globulin bound, and so there's a reduced risk for drug-drug interactions. It's got similar or higher efficacy in the over 65 age group as it does in the under 65 group, and similar incidence of adverse effects in both groups. What about impaired renal function? We know that metabolites can accumulate from other opioids, and that can be dangerous. But buprenorphine is primarily eliminated by the liver, and so that it can be used even in dialysis-dependent patients. I'm re-summarizing here all these beneficial effects. You go, this is a no-brainer, right? I mean, on paper, this is a better mousetrap. We've built a better mousetrap. Why aren't we using it? Less fracture risk, less immunosuppressant. But I want to talk for a couple minutes, I got about 2 minutes left, about my experience. These are pictures of addicts, of people with a use disorder before and after recovery. And you can see the difference in their faces, in their complexion, in their eyes, in their smiles. And I can tell you, this is what it looks like in my practice when I start somebody on buprenorphine. I'm not talking about addicts. I'm talking about people who come in with chronic pain using opioids chronically. And most of them, the higher the dose, the more so, but most of them have that tired look. It's an exhausting lifestyle, watching that clock all day, wondering when you're going to get your next dose of pain relief. And you don't sleep at night, and these people look kind of strung out, to be honest with you. And when they come back after I've started them on buprenorphine, they look different. They smile different. They move differently. And they all say that their family's telling them this, and they're just thrilled. Their families come in and hug me. It really changes. They say, I got my husband back. I got my father back. So not so fast, right? It's not just all great and easy. It's a difficult sell. You got to do motivational interviewing. I do a lot of that in my practice. You kind of got to want to do this. It takes about 15, 20 minutes for me to explain the whole process to people when they finally decide to do it. I have patients who right away come in and say, this is why I'm here, and I have patients it takes me 3 years to convince them to do this, or more. It's got this opioid use disorder baggage. People say, hey, you think I'm an addict. I have to sit and explain that to them. I enjoy doing this. I'm not sure it's for everybody. Induction is kind of tricky. This is a drug that if you take it too soon after your last opioid dose, you will go into precipitated withdrawal. So you have to spend a little time teaching people how to use it. There's not really a conversion factor. There's kind of a wide range. And there's a steep learning curve when you want to start doing this. But it's very rewarding. It's trickier when people go into the hospital or when they're having surgery. The surgeons and the hospitalists don't know how to use this drug. I've shepherded a number of patients through hip replacements and other very painful surgeries purely with buprenorphine, and they've done fabulously. but most of the time we switch them back to a short-acting, and when they're done, they come back and see me, and we quickly put them back on their buprenorphine. And then there's the X license, and it's an 8-hour course. I think it's 8 hours now. They've reduced it. It's very simple, and it's really no obstacle. We've all been through medical school. This is not a big deal. So that's it. This is my personal contact info. I have people contacting me from all over the place from the various talks I've given about buprenorphine, and I love spending time on the phone or texting, helping people. Like I said, the learning curve is steep, and so at the beginning, just be patient with yourself, and you'll really enjoy your experience with this medication. Thank you.